Today's session is the American Society of Clinical Oncology annual meeting update with Dr. Sharyn Lewin. The American Society of Clinical Oncology, known as ASCO, held its annual meeting in June 2024. We're thrilled that you joined us today to learn from Dr. Sharyn Lewin about the latest updates in the future of gynecologic cancer treatment. Dr. Sharyn Lewin is a board-certified gynecologic oncologist who specializes in the diagnosis, treatment, and management of gynecologic cancers. She serves as medical director of Holy Name Medical Center's Gynecologic Oncology Division. Dr. Lewin is the founder and executive director of the Lewin Fund to Fight Women's Cancers, responsible for the organization's operations and for setting its strategic vision. I also want to share that we are very grateful for the support of the Lewin Fund. The Lewin Fund supports many of our initiatives, such as our transportation fund, our reunion, which is on September 28th. So I hope that is on everyone's calendar, as well as our behavioral health program, which I really try to push as much as possible in these groups. So we are incredibly grateful to have Dr. Lewin join us today and always have the partnership with the Lewin Fund. Thank you so much, Dr. Lewin. The floor is yours.
Thank you so much for having me. I have to tell you, one of the most rewarding things I do is speak to the woman-to-woman group or participate in any of your activities. As I've always said, this is the most exemplary program for what we do for women in the whole country. As you may or may not know, that I was the first director of the woman-to-woman program when I worked at Columbia. That was the first pilot program modeling after your program. And that was such a success that the OCRF decided to fund that program nationally. But what Jillian and team have done there for you and everyone else, and what you've done for all the other women that are benefiting for this program, is phenomenal. And it really is the model for peer mentoring and support for women. So, we're honored to support it in any way possible and participate. And I love to talk to all of you. Please forgive me. I am recovering from an orthopedic injury that I had surgery for at HSS about 3 weeks ago. That's why my camera is off. I'm actually working from home today. I don't look as camera ready as I normally would. If you prefer that I have my camera on, let me know. I'm happy to do that. I would love to, highlight some of the exciting data that was presented at ASCO. I have a lot of exciting information to talk to you about, and I definitely want to leave ample time for questions. If for any reason you can't hear me, please let me know. I would also really love some feedback. You can even give Jillian anonymous feedback, because I love to talk to this group. I'm happy to talk on a regular basis. And there's so much exciting data that's being presented and discussed at all of our national meetings. As I was putting this talk together, I was trying to decide the best forum to present, and all the slides are very technical with a lot of numbers and a lot of data, and I didn't want you to get bogged down with any of that. So I decided just to talk through the data with you. But in the future, if it's helpful to actually see the slides and see the numbers and the data, let me know, and I'm happy to prepare slides as well. I was thinking in the time that we have, I would talk about the updates that we learned about at ASCO with cervical cancer first. Then we would speak about endometrial and uterine cancer, and then ovarian cancer, and certainly leave time for questions. If you don't mind, please write down your questions during the course of this conversation. We'll leave time at the end. Happy to really answer any of your questions. But as you know, ASCO is probably the premier cancer meeting in the world. Every year it's in Chicago in June. There are well over 40,000 participants from around the globe that come participate at this meeting. It's actually quite difficult to have any data accepted for publication and presentation there. There are a lot of oral presentations and posters. We also have our SGO meeting, which is also an annual meeting too, which is targeted just for GYN oncology. But ASCO really highlights all the cancers. So the GYN oncology portion is actually a smaller portion of the meeting, because they do spend a lot of time on breast and GI and GU and lung and other cancers as well. But first, I would love to talk a little bit about cervical cancer and some of the highlights from the cervical cancer portion of the meeting. There was one study that was presented. It's known as RTOG 724. I think maybe if someone's line could be muted.
It's somebody who does
Is that this line maybe? Are you able to mute that, Jillian? Oh, there you go. Perfect. Excellent. I don't know if I can make mine. If I share my screen, I don't know if it really matters, but you'll see my face. Anyway, so this trial basically, which in cervical cancer is called RTOG 724, was a trial that looked for women with early stage cervical cancer who had surgery, basically a radical hysterectomy, but then had high risk features after surgery. And when we say high risk features, they either had positive lymph nodes or the tissue around the cervix, which is called the perimetrium. If those areas were positive for cancer, women were then randomized to either having radiation with weekly cisplatin chemotherapy, which is what is the current standard of care, or to having that same thing, which is weekly cisplatin with radiation, followed by 4 cycles of chemotherapy with carboplatin and Taxol. And really, the purpose of this study was to see if adding chemotherapy, 4 cycles of carboplatin and Taxol, improved outcomes for these women. And essentially, what we found in this particular study, the patient characteristics were very well balanced between the two groups. About half of the women in this particular trial were white, about 40% were Asian, and then the rest had, because we always look at demographics in the studies, we look at the type of surgery these women had, we look at the cell type. About 80% of women had squamous cell cancers. That's the most common type of cervical cancer that we see. So very well balanced between the two groups. And essentially, the results show that there was really no difference between the two arms in the study. So when we see that there's no difference between the two arms in the study, it's essentially considered a negative trial. And we really found that adding those 4 cycles of chemotherapy really made no difference. So there was really no improvement in outcome for those women that had the 4 additional cycles of chemotherapy following radiation with the weekly cisplatin. What's interesting is in that particular arm, the women that were supposed to receive the 4 additional cycles of chemotherapy, about 26% of women in that arm were not able to receive chemotherapy, mostly because of performance status and toxicity issues. So it does sort of say that there are a lot of challenges with administering chemotherapy following chemoradiation in our early stage cervical cancer patients. This trial, this RTOG 724, sort of piggybacks on a trial that was presented at ASCO last year. This trial last year is called the Outback study. This was also a negative trial as well, too. This Outback trial also looked at the role of adding chemotherapy to concurrent chemotherapy and radiation for our women with cervical cancer. They actually had a bit of a broader eligibility criteria, so it wasn't just the early stage high risk patients, but they also had some more advanced stage patients as well there too. And this was also a negative trial as well. So essentially what we learned from the Outback trial, as well as this trial that was just presented at ASCO as well too, is that there really is not a role to add additional adjuvant chemotherapy or additional chemotherapy with carboplatin and Taxol to these patients that have early stage high risk cervical cancer after receiving radiation and weekly cisplatin. And so that's really important to know. Of course, when we're asking these questions, sometimes we have positive results from trials, sometimes we have negative results, but of course, the trials are always designed to ask these very important questions. And the goal is always to try and find better outcomes for patients. And sometimes, like in this particular trial, we find that the addition of more treatment actually doesn't benefit these patients. It just provides more toxicity. So this was a negative study in cervical cancer, and we learned really that there was no improvement with the addition of chemotherapy to these women. So essentially, women who have early stage high risk cervical cancer still need to have whole pelvic radiation with brachytherapy or vaginal radiation and weekly cisplatin. So that has not changed. And that was really pretty much the only, major paper of note in the realm of cervical cancer. Now we'll sort of move to talk a little bit about uterine or endometrial cancer. There's definitely a lot more to talk about when it comes to uterine or endometrial cancer, as well as ovarian cancer. So a couple of exciting things to talk about in the realm of uterine or endometrial cancer. So I'm not sure if I mentioned to this group last time we spoke, but the management for women with endometrial cancer that is advanced or recurrent has dramatically changed over the past 1 to 2 years. There were 2 really important studies. One is called the Ruby trial, and the other that is called GYO18 or GYO18 trial. These were presented at SGO not this year, but last year, and subsequently published in the New England Journal of Medicine. So these were 2 sentinel studies that really changed the initial treatment for women with advanced or recurrent endometrial cancer. And updates to these practice-changing trials were also discussed at ASCO this past year. So prior to the presentation with these 2 trials, women were only receiving carbotaxol. In this setting, these 2 trials looked at the addition of adding immunotherapy or a checkpoint inhibitor to chemotherapy with these women, followed by immunotherapy or checkpoint inhibitor maintenance. And what we saw in both of these trials is that of a dramatic improvement in the outcomes for women when they had immunotherapy, also known as a checkpoint inhibitor, added to chemotherapy, followed by maintenance with the immunotherapy or checkpoint inhibitor as well. And so what we saw at ASCO this year were just some updates to this trial as well. We looked at the overall survival, which means how long women lived in the Ruby study. And, when we're talking about endometrial cancer, we look at sort of 2 subtypes of women with endometrial cancer. You may hear some of this terminology. One subset is called DMMR or deficient in MMMR, and another is called proficient or PMMR. They're basically 2 subsets of women with endometrial cancer. We determine this based on doing staining or immunohistochemistry of the tumor. This is something that the pathologists do on the tumor itself. It's very standard of care that this is done at the time of hysterectomy or endometrial biopsy or DNC. But all of these studies sort of break down outcomes based on women that have either DMMR in their tumors or PMMR in their tumors. And what this DMMR, PMMR means, basically for us as clinicians, is it's a way of DNA mismatch repair that's happening in the tumor itself. So basically the trials just broke down outcomes in terms of how long women remained cancer-free and how long they lived based on the DMMR and PMMR status. And we saw an impressive overall survival benefit, how long these women lived, statistically significant, dramatically improved with both women subsets that have the DMMR and the PMMR, essentially the entire population who had immunotherapy with chemotherapy, followed by immunotherapy maintenance. So a lot of big words, and I don't want to get too lost in all of these big words, but really, truly the standard of care now, which is practice changing and has really changed the landscape for our women with advanced endometrial cancer, which pretty much means stage 3 and 4, or recurrent endometrial cancer, is to give immunotherapy with chemotherapy, carbotaxol, and then immunotherapy maintenance. And we see that women are now living longer and cancer-free longer because of this. So at ASCO, they talked about this, and they also looked at some molecular subgroups of the patients within these studies. And they really found that all patients, sort of regardless of their mismatch repair mechanisms, really benefited from immunotherapy. And all of the groups benefited from the immunotherapy to a really maximal extent, except for one particular subtype, which is called P53 wild type. And please stop me or put your hand up if I'm getting too technical, because I don't want to get too technical. This is why I thought I might talk through this rather than just show you a bunch of slides with numbers, because I don't want you guys to get too bogged down with numbers and slides and things like this. But this P53 wild type is a very interesting subgroup, which sort of leads me to talk about the next trial that was talked about at ASCO, which talks about a drug. It's called selinexor. And they had an oral presentation about a drug called selinexor. It's spelled Selinexor. And this is a drug that had very excellent outcomes. It's used as a maintenance, and it's really for patients that have this P53 wild type in their tumors. And I think what all of this data shows is that we as GYN oncologists for endometrial and uterine cancer really need to be doing biomarker testing on the tumors. And I'm sure your GYN oncologists at Mount Sinai are all doing this as well, because Mount Sinai is an excellent institution, but we're educating the community about the importance of taking the tumor when you're, diagnosed with cancer, particularly endometrial or uterine cancer, and sending it to the lab so this thing called next-gen sequencing can be done, and they can profile your tumor looking for these things that I've been mentioning, these big names like DMMR and PMMR or P53 wild type. Sometimes the pathology departments are doing this in the hospitals themselves. Sometimes it's a send-out lab. But now we are really able to classify endometrial and uterine cancers based on these molecular subtypes, and now having these targeted therapies for women really based on these tumor characteristics. So essentially, in this update to the selinexor maintenance trial, these women were all randomized. These women had, this was an important phase 3 trial that looked at giving women carbotaxol, and then selinexor or placebo as maintenance. And women were treated until progression or some type of unacceptable toxicity. And in this update trial that was presented, we saw that the women whose tumors had this P53 wild type expression really had a very impressive improvement in the amount of time that they remained cancer-free if they had this drug selinexor as maintenance. And selinexor basically, is, how do I best explain that? So it helps keep this P53 in the nucleus itself. And it specifically targets these with biomarker negative, which is also called P53 wild type. And so that's where we really saw the maximum benefit of this drug. I think just like all of oncology, we've really moved towards personalized medicine, where we're finding these particular targets in the tumor itself and these particular drugs that actually target those particular targets and work the best in certain subpopulations of patients. So the name of the trial, it was called SIENDO, SIENDO, which essentially looked at this drug selinexor as a maintenance drug. So after women received carbotaxol chemotherapy, they had selinexor as maintenance or placebo, and they will treat it, as I mentioned, until progression or toxicity. And when we look at the subgroups, the women that really, really benefited from this treatment were the ones whose tumors were biomarker negative, that they had no expression of this P53, which is also known as wild type. And essentially, these women remained cancer-free so much longer. And so it's an interesting, exciting target for these particular women once they finish chemotherapy to have this drug as maintenance. And so this was definitely a very exciting update that was presented in the realm of endometrial cancer. And we saw that there was a real benefit for selinexor in the biomarker negative, the P53 wild type regardless if it was proficient or deficient in MMR, the D or pMMR. Another update in the realm of endometrial cancer, DUO-E is another study that was presented a while ago, but at ASCO this year, DUO-E looked at another immunotherapy drug. It's called durvalumab. DUO-E looked at a subset of women. Durvalumab was used in combination with carbotaxol, followed by durvalumab maintenance, which is another type of checkpoint inhibitor or immunotherapy with or without olaparib, which is a PARP inhibitor. Sort of interesting, one of the first trials to look at the use of a PARP inhibitor in endometrial cancer. So at ASCO, they looked at the subset of patients with BRCA mutations. This was a poster that looked at the response rate in our BRCA mutated patients. And it was just interesting to see the positive response in our BRCA positive patients. So just more hypothesis generating and just interesting data overall as well. Let me see. There was also a benefit I should have mentioned in overall survival in the selinexor study as well too. Hope I haven't lost anybody yet. Is this too technical?
What does everybody think? I'd love to hear from the group.
No, this is great. But I'd love to know how to spell some of these drugs.
Oh, sure. Absolutely. Maybe I should make slides just to spell it. Okay, which drugs would you like spelled?
All of them.
All of them.
Yeah, I just and if you can correlate them with the different relevant biomarkers, if that makes sense to you. Maybe I don't know how to say it.
Yes. Here, let me go back. It is a little technical, but enough to do further research. Has any of this trial data been published? Some of it has been published or in the process of being published, yes. Oh, that's a great question. So some of these things, to be honest, so even though some of this data may get presented, and even get published, it does have to be sort of in NCCN guidelines in order for it to really become standard of care. So even though we present data at ASCO and it may be, published in journals, that doesn't quite lend itself to a change in the standard of care. It has to be very impressive data. And in order for it to be a standard of care and a change that leads to a standard of care, it sort of has to go before the FDA and the committee of NCCN. It's a whole nother layer of changes. So I just want to back up for one quick second. So like when I spoke about the Ruby trial and the GYO018, those were both presented at SGO last year. They were also published in the New England Journal of Medicine. And at the same time, the pharmaceutical companies presented all of that data to the FDA. And the FDA reviewed all of that clinical data. And then months later, I can't exactly remember exactly the timeline, but some of it was actually rapidly. The FDA issued a label for those drugs, for those specific indications for those cancers, and then it was updated in NCCN. So that's kind of what I mean by standard of care changing. That's sort of what has to happen for the standard of care to change. But often what happens if there's such groundbreaking research that is presented, at the same time that it's presented, the publication is already submitted and published because they're kind of working on it behind the scenes. And then the companies, submit to the FDA and NCCN for approval. So that's kind of what I mean by the standard of care changing. Some of these other smaller data abstracts that I'm presenting to you are really just data that's presented, that's interesting, that's kind of provocative and good to know about. It doesn't necessarily mean the standard of care has changed yet. Some of these drugs may not yet have an FDA indication in this particular subtype. So it's sort of like more to come.
Thank you.
So I think for all of you, the only standard of care thing that I've really mentioned so far is the use of immunotherapy or checkpoint inhibitors for advanced endometrial cancer. So if someone is now diagnosed with a stage 3 or stage 4 endometrial cancer or a recurrent endometrial cancer, she will be talked to about receiving carbotaxol with immunotherapy. It'll either be Keytruda or it'll be like dostarlimab. Jemperli is the other name for it. Those were practice-changing standard of care regimens, based on how impressive the improvement was in outcomes for women, based on those trials and that data. I wouldn't worry too much about focusing on the names of the drugs and the biomarkers, because I know all the doctors that are taking care of you guys, and they're all up to date on all of this data, and they're sending your tumors for molecular profiling and looking for these targets. I think I was just more hoping that this talk would be just to give you an idea of the research that's happening out there and the clinical trials and the data that's being presented. I think that that's really more important than maybe writing down so much the details of the drugs, if that's okay. I think I think maybe of the things I've mentioned so far, the selinexor would probably be the most important thing to look out for. Let me spell that name for you. It's Selinexor. I could also write that in the chat. Selinexor. And that's just a maintenance option for women that are specifically P53 wild type. So that's not necessarily for everyone. But then again, that's not been FDA approved or listed in NCCN yet, so we're not quite there yet. But that hopefully is on the horizon. I think this is a good way that we also ensure safety for patients too, is that, trials are presented and published, and, these get published in peer-reviewed journals. Of course, there are some peer-reviewed journals are better than others. Like, to get things published in the New England Journal of Medicine is extremely difficult, or the JCO, for example. But then it also requires going to the FDA, which is a whole nother level of rigor. The FDA committees evaluate this data. Sometimes there is rapid acceleration of approvals when things are really groundbreaking and then there's a real unmet need. A good example of that would be like mirvetuximab was initially rapidly accelerated for patients with alpha folate receptor platinum-resistant ovarian cancer. And then when the confirmatory trial was released, they had full approval. But this is designed to protect patients, but also to have access to drugs. And then there are changes based on NCCN guidelines as well, too. So some of the things that I'm talking about today, we have the data for, but it hasn't necessarily made it to FDA approval and NCCN. Although sometimes we can argue for like compassionate use of drugs for patients, and sometimes we can use off-label use of drugs as well too. So that's kind of a nutshell as well. I hope that answers the questions. Let me see about everything in the chat. Did I address all of those, Jillian? I know you're probably looking at this too. If the standard of care is changed while someone is on active treatment, we do follow the standard of care, because sometimes that does happen. Yes, some of the trial data has been published that you can access yourselves elsewhere. It'll also be extremely technical to review as well, too. We'll talk about the Keytruda for endometrial cancer. Let me come back to that one at the end.
I guess maybe a question is, and I didn't write it in the chat, but it sounds like people are wondering that they don't have as much information as you're providing to them from their physicians. So maybe how do they ask questions about this? Does that sound useful to the group from your perspective as a gynecologic oncologist? If patients have questions about these types of things, what would be the best way to ask? Would that be useful for everyone to just sort of have some guidance from a doctor about how to ask questions about the wild, like I'm looking at Allison's point about the P53 wild type.
Yeah, you know what?
Arlene said she feels like she hears sometimes more education from our educational talks than from her physicians.
Oh,
So
I
how
see.
could patients ask questions from their doctors to understand more? I hope I'm being clear.
Yes, I hope this answers
All
it. So maybe a nice way to say it would be, I participate in a lot of support groups, and I hear there's a lot of talk among the women about the importance of doing tumor testing to learn more about my cancer. Can you tell me, if any tumor testing has been done on the type of cancer that I have? Tumor testing and molecular testing, that's the same thing, but tumor testing is more of a layperson's way to say it. I guess as a patient, I would expect you to say, I'm the doctor, right? I would expect my patients to say to me, Dr. Lewin, has any tumor testing been done on my type of cancer? I guess molecular testing is probably more of a technical term, but you could say either one. But I would expect my patients to say to me, Dr. Lewin, has any tumor testing been done on my type of tumor? Patients do say this to me, by the way. And if so, like, are there any targets on my particular tumor, any drugs that would be helpful in my care? Could I have a copy of any of that tumor testing? I mean, you can have a copy of these things. Of course, you can have access to all of your records. And you should say, like, are there any targets in my tumor that make any treatments, unique for me? There's so much talk now about personalized medicine and targeted treatment. I'm sure you'll find this in any of the support groups, any of the chat groups, any of these things online or in person, that it would be very natural to say this to your doctors. I think that would be a very comfortable, non-confrontational thing to say. Just like I hope all of you have had genetic testing who qualify for it. And as we've talked about in other meetings, do you know your BRCA status? Do you know your genetic status? Like, you should all advocate for yourself and know, do you need genetic testing? And if you do need it, what are your results? And I think it's fine to say, do I need any tumor testing? And if I do, have I had it? What are the results? A lot of times our doctors have done these things. And patients, most of my patients have not asked if they've had tumor testing done. So it's very technical. So I kind of don't share it with them because they haven't asked. It's something that I know and I have it in their records. And I'm looking to see if there are certain targets for them, but they haven't asked. So I don't want to overwhelm them. So I haven't shared it with them. I'm sure your doctors have all done it for you and it's in your records. Maybe they feel the same way, that since you haven't asked, they haven't shared it, but it's there. Does that answer your question?
It does answer my question. Thank you.
Okay. I'm just reading the chat to be sure I answered anything. So tumor testing, we are educating everyone that it really should be standard. For example, Caris result, that is one evidence of tumor testing. So there are various different companies on the market that do tumor testing. Caris is one company. Precise from Myriad is another company. Foundation Medicine is another company. Caris, oh, I said that. And Tempus, for example. There are some institutions that do their own in-house testing, like Sloan Kettering has Impact, which is in-house testing. Pretty much all these tumor testing, they test the same thing, so it's all the same thing. The Invitae that someone mentioned, that's germline, that's genetic testing, that's different. So that's actually looking for genetic testing like a BRCA mutation or testing for Lynch, but tumor testing is actually what the Caris is. And it looks like Allison asked your Genonc for a copy. So that's where you'll find in that Caris report the P53 wild type. You'll see some of these things that I've mentioned in that Caris report. That's the tumor testing. I'm pretty sure it's probably been done for all of you. It's just not been talked about, but I'm sure it's actually in your chart. It's actually a pretty good thing to talk about. Maybe I should have started the conversation with talking about the difference between genetic and tumor testing, because, really tumor testing, we want it to be standard of care now, especially now that there's been so much clinical trial work in endometrial and uterine cancer and learning about these targets and the drugs that target these certain targets. A lot of times some tumor testing has been reserved for the recurrent setting, but now we know that these targets are very important in the newly diagnosed setting. So we've been trying to encourage providers to do this molecular targeting when women are diagnosed, not only for uterine and endometrial cancer, but cervix and ovarian cancer as well too. So I think that's very important as well. I think that's probably a very good thing to talk about in this session as well too. And I think actually those were probably the highlights from an endometrial or uterine cancer standpoint as well. Those are actually great questions that you asked.
Are there any other questions in terms of the endometrial uterine standpoint for Dr. Lewin? Okay.
Yeah, I have to say that ASCO this year was nothing like earth-shattering was presented, if I may say. There are some years for GYN oncology where it's been like, wow, groundbreaking, changing things. There was nothing like that this past particular year. So, we'll kind of move to talk a little bit about ovarian cancer, but yeah, like this year at ASCO was nothing like earth-shattering or groundbreaking. So, but it's still nice to talk about some of the updates. So when we're looking at ovarian cancer, there are just a few trials I think that are worth mentioning. One of the more interesting trials was looking at the role of immunotherapy in our women with clear cell ovarian cancers. It's a certain cell type of ovarian cancer, and in that population, they also had some other extrarenal clear cell cancers. Clear cell cancers tend to be kind of resistant to chemotherapy. This was actually a phase 2 trial, and it used two forms of immunotherapy. And they actually found a very impressive response rate for these clear cell ovarian cancers that used two forms of immunotherapy together. So this was actually a very interesting trial. The drug names are pretty complicated to pronounce. I'm happy to type them into the chat if you want, but I think maybe just giving you a general idea of the concepts would be very helpful. I think that was probably one of the more interesting trials that was presented, and we definitely know that for women with clear cell ovarian and uterine cancers, that there is an important role of immunotherapy in these women. Marisol was a phase 3 study that was presented last year. This year, they talked about the fact that Marisol, which is looking at mirvetuximab, I'm sure you're familiar with that drug, also known as Elahere. They looked at that data in our elderly patients, and they know that elderly women responded well to treatment with minimal toxicity. So that was interesting to see. There was also another study looking at the role of pembrolizumab, also known as Keytruda, with the oral drug Lenvima. This is a regimen that we commonly use in endometrial cancer, but here they actually looked at it in women with platinum-sensitive recurrent ovarian cancer, and there was a nice response rate as well too. Data from an interesting phase 3 trial looking at the role of adding a drug called atezo in women with platinum-resistant ovarian cancer, adding this to either weekly Taxol with Avastin or Doxil and Avastin. This was a phase 3 trial. Unfortunately, this was what's called a negative trial, so we really saw no difference to adding atezo to this regimen. Right now the standard of care for platinum-resistant ovarian cancer is weekly Taxol with Avastin or Doxil with Avastin. But again, this trial was designed by adding a third agent or not to see if there was any benefit. And essentially this was a negative trial, so really no benefit to adding atezo, although we were seeing some signal in certain select groups. So that was interesting to see. And then there were also, as I said, nothing that was really earth-shattering. There was another trial called Accelerate. Unfortunately, this was also a negative trial as well. This was a negative trial means it does not meet its primary endpoint. But again, in patients, this was a platinum-resistant ovarian cancer trial. This particular drug that's called AVB, there was some excellent signal in the patients that have AXL expression or high expression. So this is something that, even though it wasn't an analytic endpoint in the trial, it's something that people are going to explore and study more in the future. And I think lastly, the thing that I will mention before we really go on to questions is that there was a surgical trial that was presented called the Carcio trial. This was a randomized trial where women who had chemotherapy first, and then they were randomized to surgery with removing lymph nodes or surgery without removing lymph nodes. And they basically found that removing normal lymph nodes was really not necessary. It led to sort of a higher complication or morbidity rate with no change in outcome. So essentially that if lymph nodes are normal, we really don't need to remove them. So less surgery sometimes is better. And it did not really hinder cancer outcome. So, and this is pretty similar to an upfront trial that we had seen before called the Lions trial. So again, nothing that was really earth-shattering, but some really kind of provocative questions and things of interest for the future. I guess I've spoken a lot at this point. Maybe I'll stop and get to all the questions.
I actually had a question. Was any update about PARPs or the length of their use mentioned? Or is there any update that we should know about? I feel like that comes up often in our groups.
It definitely does. Still really the standard. Some of that updated data was presented at other international meetings like ESMO. So for example, the 7-year overall survival data from the initial SOLO-1 has been presented this past year. I don't know if I've spoken to your group about it. So for our women with BRCA1 and 2 mutations who have chemo and then take Lynparza, for example, for 2 years as maintenance and then come off, we see an incredible survival advantage. They presented that 7-year data this past year, not at ASCO, but that's been presented. And also the PALA-1 data, that 5-year data was also presented this past year. That's using Avastin with chemotherapy, followed by Avastin maintenance with Lynparza. In our women that have HRD, there's also a very impressive survival benefit there as well too. So nothing really new in terms of the indications, but just data that really reinforces the importance of these regimens, keeping women cancer-free and living longer.
Thank you. Marlene, I see your hand is up and you had written some stuff in the chat. Marlene.
Yeah, I was just going to ask, how is this information, if it is disseminated to GYN oncologists, is it normally or routinely something that is provided or accessed by an average GYN oncologist? I mean, is it generally available, or do you have to, as a doctor, solicit the information or find it yourself?
Yes, it's definitely generally available to GYN oncologists. So if people, don't go to the meeting, there are definitely publications in all of our peer-reviewed journals. There are publications in lay journals. They have videos that reiterate the presentations. There's a lot of different ways to get this information. Yes, it's readily disseminated on all channels.
And I have a question about FDA approval and all. Is it generally something that takes years to do, or does it vary with the different types of studies in terms of the gynecological cancer ones you spoke about?
Great question. So no, not at all. So if something is groundbreaking and extremely effective and it's in an unmet need, then it can be rapid acceleration. So like a great example is Elahere or mirvetuximab. You can have rapid acceleration based on that data, where things happen very quickly once that data is presented and published. within a few months. But then the FDA also reviews the confirmatory trial data as well, just to ensure that it is still safe and effective once the larger pool of data set is published. So no, it's a balance between safety, providing things that are safe for patients and also effective. They don't want to withhold any medications for patients, but it's also a balance between safety and effectiveness.
I have a question about patient education. I'm not familiar with a lot of what you talked about today, but as I said, you presented enough that allows me to research it further. Do you know of any documentation that exists from either a cancer association or a gynecological oncologist association that briefly gives you like what I would call a primer on understanding some of this phraseology and the wording? Because even if you have access to information, if you have no clue what X, Y, and Z is, it really, you can't even formulate a question for your doctor because you basically don't understand. Are you aware of any such resource that a patient could go to and educate themselves about the various, terminology that's been used, for example, today and in the presentation? Obviously, if you're a patient who as a doctor who's gone over with this with all of you, you have a better understanding. But some of us have not had that experience, nor has it been necessitated at present, but we would like to keep up with it. Just was wondering if you had a source for that kind of information to educate ourselves.
Yeah, great question. I mean, the Society of GYN Oncology does have patient resources. I'm just looking at it now as we speak. It's sgo.org patient resources. I wonder if it has this terminology on there, though. I don't know how detailed it is in terms of having this type of, I mean, it has the basics about the GYN oncology. I should put that on our website.
It kind of makes me wonder why doctors today don't, not an individual doctor, obviously, it would be too much work, but why there isn't really, there's so much stuff out there in cancer from various resources, but I haven't seen a lot that really helps people to understand what's going on with immunotherapy, tumor testing, all of these things that are really relevant to certain diagnoses. And, perhaps people are getting these things when they're diagnosed, but some of us might like to know, at the moment, as opposed to in the moment when, you're relying on someone else.
That is such great feedback. And I'm going to take that back. I'm going to take that back for improvement. That is great feedback. You're completely right.
I do spend my life in communications, and that's why I bring it up, because
I think you're completely right.
Yeah, I spent my life working for clients who do not in the medical or scientific, but in other areas. And one of the things that's most in demand for their clients is just a simple explanation to get them started with some of these things. And you are the perfect kind of person because your ability to communicate is excellent. And so, other doctors are like you, they can, put their heads together and create something. It would be fantastic. Thank you.
I think that is a really excellent idea. I think we have not done that well on the websites. I have not seen it that done well on any of the websites, to be honest. I'm going to look for a site. If I find one, I'll let Jillian know, but we have not done that well. You're completely right.
And in terms of also, Marlene, your question about how do doctors get this information, I could say in terms of Mount Sinai that multiple members of the Gyn-Onc team go to ASCO. My assumption is that's the same case, and Dr. Lewin, you would know better than me, but that's the case from all of the major treatment centers. We have a couple more minutes with Dr. Lewin, which I always find very precious. So are there other questions? Not to put Catherine on the spot, but I do have a question thinking about her. Was there any other updates in terms of clear cell, Dr. Lewin?
No, I think this trial is definitely very provocative. One thing that is very exciting in GYN is a drug called Enhertu. I don't know if any of you have heard about this. We're doing tumor testing for the overexpression of HER2. This is something that the pathologist can do, like at Holy Name. Our pathologists are doing this immunohistochemistry testing on the tumor itself. but this has been an update in NCCN based on data that was presented at ASCO last year. But this drug Enhertu, for example, is used a lot in breast cancer. And now this data was presented last year looking at lots of different types of cancers. But we see it's called Destiny Pan-Tumor was the data that was presented last year. But in HER2, in our gynecologic patients that have overexpression of HER2 have had excellent responses to this drug in HER2, whether it's cervix, ovarian, endometrial. I have a patient now with clear cell ovarian cancer on Enhertu who has had a dramatic response to this drug. But if she progresses on this regimen, the next thing we'll think about are these 2 immunotherapy drugs that I mentioned in this particular trial.
Can I ask a quick question while I have
Of course.
you? So I'm curious about some of the things that I can do as a patient currently undergoing chemoimmunotherapy based on the current standard of care. And things like food, exercise, sleep, all of these things are concurrent, but not really addressed other than do what you feel you can handle. Like there's just, it's difficult. Is this like a social work thing? Is this a nutritionist thing? Is this the oncologist's nurse practitioner question? Like, who are the best people to reach out to get some kind of feedback on what is how I should interpret how I'm feeling? Because it's just not always sufficient to be saying, oh, well, just go with how you feel.
You know what? I think all the people that you mentioned, so all those strategies that you mentioned are really important when you're on treatment. We know the importance. There's a lot of data about the importance of exercise for our patients who are on treatment and people who have had cancer and are not on treatment as well. Exercise is very important for all of us. There's just so much data about that, but especially for our patients who are on treatment or who have had a history of cancer. Nutrition is critically important. I think all the people that you mentioned are good resources. If I would use your nutritionist, the social worker, the women to women, all these people that you mentioned are all excellent resources. Not just being on immunotherapy, but just being on treatment in general. There's so much data for all of us, but especially our women who are on treatment about the importance of diet, exercise, good sleep. All of these things that you mentioned are very important if you can do it.
Well, that's the element that's always a moving target, because they're like, well, what can you tolerate? Well, what is tolerate? I mean, these things are so individualized that I understand it's often a challenge for anyone who's treating somebody. Like my doctor's like, well, I had a patient who kept running 5 miles every day. And I'm like, holy crap, how do you do that? Like I'm lucky that I'm able to some days, just do my laundry. So,
Yeah.
It's hard to gauge things.
That is a day-to-day thing for some patients, and everyone is different. People come into their treatment with a different baseline, and every treatment is different, and every treatment affects different patients differently.
Yeah.
I would talk to the social workers and the nutritionists. Honestly, I would see if you can get into some type of a physical therapy program if you're able to. Jillian might have a better handle on the resources that are available. We've found here that like Kessler has developed a great program for gynecologic oncology patients who are on treatment and after treatment. There may be some great resources to help for women who are on chemotherapy and such. I'm sure you have that, right, Jillian?
Yeah, I was going to say that I could email you a few things. We have kind of like questions, resources to ask your team, but I don't think that you attend our general group that we meet on Wednesdays at noon might be helpful for you, kind of to hearing from others that are in treatment or post-treatment, just in terms of from their process. And I think for people who are in treatment, at some point you sort of learn like the cycle of how you're feeling. Like people say that they could anticipate, well, like the first 3 days after my treatment, I'm really active because of all the steroids, or maybe that's 2 days, and then I'll crash and I feel like garbage for a week. And then like you sort of learn your cycle and could anticipate.
So,
Well,
anyway,
look, I always
thank you
tell
so much.
people, tell 10 women about gynecologic cancers, because we do know that half of women who are diagnosed with GYN cancers never knew the signs or symptoms before they were diagnosed. So if all of you could go out and tell 10 of your friends about the signs and symptoms and then tell them to tell 10 other people, we will really do a lot to educate, because women don't talk about these things, and we don't do a lot to educate people about the signs and symptoms and the importance of seeing your gynecologist every year. And so we need to do this. A lot of women, once they have their children, they stop going to the gynecologist and things of that sort. So we really need to be advocates and educate each other about the importance.
I agree 110%. There should be things like everybody knows about mammograms. Like it's I get reminders
I know.
like
Well, we're
where
working on this.
reminders.
Tell
So,
10 women, ladies.
yeah. All right.
Lewin, thank you so much, Dr.
Thanks,
Lewin.
Jillian. Always happy to come
Love to
talk.
have you with us, and thank you for your time and for the support of the Lewin Fund. Everyone,
Anytime.
have a wonderful rest of your day, and enjoy the beautiful weather.
Thank you so much. Feel free to give Jillian any feedback anonymously. She can tell me too, anonymously. I'm happy to make improvements for the next time. Okay. Thank you all.
Thank you.
Have a
Thank
good
you
day.
so
Thank
much.
you. Take care. Bye-bye.